Today we're going to look at ethics surrounding physical restraint use, how these principles relate to laws and regulations, and how they, along with other resources, can help guide decision making in your practice as a nurse practitioner. First, let's talk about what a physical restraint is. The Substance Abuse and Mental Health Services Administration defines restraint as any method, physical or mechanical device, or material or equipment that immobilizes or reduces an individual's ability to freely move his or her arms, legs, body, or head. Limiting a person's freedom in this manner brings into question patient rights and many bioethical concerns. Under the principle of autonomy, patients have a right to make choices in their care, and healthcare professionals are expected to respect those choices. Involuntarily placing a patient in restraints compromises their autonomy. Healthcare professionals also have a duty to do good to their patients and protect them from harm, which falls in line with the principles of beneficence and non-malfeasance. Several reports and legal cases have shown restraints can cause physical and psychological harm. Here are a few instances where such was the case. In the case of Larry Gosta versus Pima County, a female patient was held face down while being manually restrained by mental health techs. They put a pillow under her head to protect it. The patient died of asphyxiation. In Davis versus Rennie, at a Massachusetts state hospital, a patient was restrained after returning from elopement where the patient escaped and went out drinking with a peer. In restraints, the patient was physically injured by a staff member and also reported psychological injuries. Also, the National Alliance for Mental Illness published a report in the year 2000 called Cries of Anguish, which included nearly 50 instances of neglect, physical and psychological abuse while a patient was in restraints in the preceding 2 years. Some of these cases resulted in death. In the use of restraints, healthcare professionals are responsible for protecting patients' basic human rights to life, personal liberty, physical integrity, and freedom from cruel and unusual punishment or unnecessary use of restraints. The Healthcare Financing Administration further asserts patients have the right not to be restrained unless it is medically necessary, and it should not be used as a means of coercion, discipline, convenience, or retaliation by staff. As you can see, on too many occasions, these rights are not being protected. Studies show this is largely due to incorrect application of restraints, failure to assess or observe the patient while in restraints, and poor staff education on restraint practice, which all leads to harm of the patient. According to Mental Health America, restraints have no therapeutic value. So why do we use restraints with these ethical concerns and the potential for harm? Alternative therapies do not always work. In emergency situations with an overly aggressive patient, restraints may be needed to prevent adverse outcomes and serious injury to patients, family members, or staff. The use of restraint is justified as a means to assure safety. Per the Joint Commission, it should only be used in emergency situations after all less restrictive interventions have been unsuccessful. When the use of restraints has become absolutely unavoidable, there are guidelines and regulations endorsed by CMS and Joint Commission that should be followed to reduce the potential for harm and to protect the patient. In these unavoidable times, it's important to note, once you as a nurse practitioner order a patient to go on restraints and take away their freedom, you assume a fiduciary responsibility. A fiduciary responsibility is the ethical duty to protect the patient and act in their best interest as a parent or guardian would. This responsibility means you could become liable if the patient is not properly monitored. Take a look at these two cases. In Road versus Lawrence General Hospital, police found a man at the scene of a car accident. Because he appeared to be suffering from mental illness, he was taken to the hospital. At the hospital, he assaulted a staff member, was assessed by a physician, and ordered to be placed in 4-point restraints. An hour later, he got himself out of the restraints and escaped from the hospital. He stole a car that was in the parking lot, ended up crashing it, and sustaining serious injuries. He later sued the hospital for not properly putting on the restraints and failing to monitor him in the restraints. The court ruled in his favor, citing negligence against the hospital. In another case, Marvel versus County of Erie, a patient presented to the ED and was involuntarily admitted and placed in restraints. After he had been in restraints for a while, a resident came in to assess him. 15 minutes after the resident left the room, the man was able to free himself from the restraints. He ended up going to the balcony of the hospital, hung over it, and fell 20 feet to the ground, sustaining multiple injuries. He sued the hospital as well. The court cited negligence in this case as well for failing to properly monitor him and for the resident failing to assess the restraints while he was in the room with the patient. As you can see, the use of restraints can become a risky situation for the patient as well as healthcare professionals and healthcare institutions. Due to the negative outcomes and the extent of the ethical issues surrounding restraint use, healthcare associated organizations and accrediting agencies are now pushing for serious reduction of the use of restraints, leading to ultimate elimination. Many psychiatric facilities across the U.S. have reported development and implementation of alternative therapies to better address aggressive behavior and efforts to reduce the use of physical restraints. Organizations such as Mental Health America, National Alliance for Mental Illness, Georgia Advocacy Organization, and National Psychiatric Nurses Association have all issued position statements advocating for the elimination of restraints. Although many agencies feel strongly about restraint elimination, studies show there is currently a lack of evidence showing these efforts are being successful. There is still a great need for encouragement and education in this area. Mental health organizations like the Substance Abuse and Mental Health Services Administration and American Psychiatric Nurses Association provide a lot of free resources to help educate individuals about restraint reduction and alternative therapies. Let's talk about how this information and these resources can help guide decision-making in clinical practice for you. In considering physical restraints as a form of treatment, remember the following. Only use restraints in emergency situations when there is imminent risk of the patient hurting themselves or someone else. Before putting in the order, ensure the least restrictive therapies have been attempted first. Promote and encourage alternative therapies. And please note, although there are similar ethical concerns regarding seclusion as well, seclusion is considered less restrictive than restraints. Within 1 hour of the restraint order, the practitioner must assess and evaluate the patient. Use that time to ensure the restraints are secure, check for bodily injuries, and assess whether the patient is ready to come out of restraints. Restraints must be discontinued at the earliest possible time. Let's go over this practice scenario. At 5:30 p.m., you get a call from a nurse on the residential psych unit. She reports patient J is pacing back and forth in the day room with his fist balled up, yelling that somebody took his lucky hat and threatening to hit the other patients in the room. The nurse states verbal intervention isn't working and requests a medication order and manual restraint to administer it. What do you do? A. Tell the nurse to keep trying to talk to him and call you back if he becomes aggressive. B. Give the nurse an order for manual restraint up to 5 minutes and Ativan 2 milligrams IM now. C. Have the nurse tell him he can calm down or go in mechanical restraints. D. Tell the nurse to take him to the dining room and give him his 7 p.m. PO Haldol early. If you chose D, you are correct. The least restrictive measure would be to decrease stimulus by taking him to a quieter environment away from the peers he is threatening. Here, verbal intervention may be more effective along with the antipsychotic he is already prescribed. Great job. What questions do you have?